Good afternoon. Let's go ahead and get this session started. My name is Dana Anderson. I'm very happy to be here to preside over a discussion that's really a continuation of the NIDDK workshop that we held on Wednesday. If I could have my first slide. Interventions for pancreatitis, for those of you who may have missed it. Next slide, please. This is really a continuation of a series of workshops that we have organized over the past few years, very happily in partnership with Pancreas Fest. And the purpose of these workshops has really been to explore, to educate, to understand what the needs are, what the design should be, what the uniform style should be for clinical trials that will be appropriate and meet the requirements of the Food and Drug Administration in terms of testing and hopefully advancing drug therapies for all forms of pancreatitis. You are acutely aware of the fact that there are no currently approved drugs for acute or chronic pancreatitis. And one of our clinical missions is to assist investigators in developing clinical trial strategies that in fact will result in a change in that circumstance. And so we're going to begin our program today first by summarizing what happened at that workshop on Wednesday, and that will lead us into a discussion of some more specific issues regarding clinical trials. Our workshop on Wednesday was co-chaired by Dr. Anna Evans Phillips of the University of Pittsburgh and Dr. Stephen Hughes of the University of Florida, and Dr. Hughes is going to summarize the workshop for us. Dr. Hughes.
Good afternoon, everybody, and thanks for sticking it out. This is the most important session. I really want to thank the NIDDK for sponsoring this workshop. I got great value out of it, and I hope to surmise a very full day of content in about 15 minutes. I want to apologize to the presenters. Obviously, I can't provide the kind of detail you provided to the audience there on Wednesday, but I've tried to glean some of the key points from each of the topics that were covered. Let me make sure I can get this button working. Just, I at the finish have put together 2 pages of recommendations, which are my first pass at what will be ultimately put into a manuscript that will be published in Pancreas early this fall. All the participants in the workshop will have an opportunity to vet that manuscript. So if there's something on here you don't like, let me know. It was broken down into 4 sessions. The first was behavioral interventions in pancreatitis. And before we dive into that, wait a second. How did I jump so far ahead? There we go. We started out the workshop with Chris Forsmark, who gave a very nice summary of the current status of the field. I really enjoyed his talk in that he really focused on advances that had occurred in his career, emphasizing conversations about the understanding of alcohol versus genetic contributions to the etiology, the role of smoking, that amylase and lipase levels don't necessarily spike with subsequent acute episodes, that endoscopic ultrasound isn't necessarily perfect and maybe too sensitive, that celiac blocks aren't effective, that exocrine insufficiency is a very common problem and was previously undertreated. And furthermore, diabetes also is not an uncommon problem and actually is rather difficult to treat in this group of patients. He set some goals for the group, wanting to focus on prevention, mitigate progression, symptom management, improving quality of life and function, preventing complications such as sarcopenia and depression, suicide, opioid use disorder, the induction of poverty in these patients, the shortened life expectancy they have, and then ultimately the hope of reversing the disease. Shortly after that, we had a wonderful opportunity to listen to Adriana Cowden, who is now our executive director of the NPF. She is a chronic pancreatitis patient and had the courage to actually deliver her address from a hospital room. She's an amazing woman, and she's had the typical things that really made us kind of galvanize as a group. 16 ERCPs, 7 different feeding tubes, cholecystectomy, Whipple, TPIAT, 3 subsequent abdominal operations. She has got intestinal dysmotility, some liver disease, other endocrine disorders, and yes, in fact, does have bone disease and has had DVT complications from her need for parenteral nutrition. She went on to talk about the devastating aspects of the disease, loss of good friends, getting fired from a very productive job, losing her home, losing her luxury car, being identified as being unreliable, or as tagged as a drug seeker. And at the end of the day, she really emphasized 2 things to me, which is indeed what we've talked about. Pain is a key symptom in this disease process, but she also really drew attention to the room, how significant her nausea was in affecting her quality of life. We then jumped into the first session, as defined behavioral interventions in pancreatitis. This was started by Tanya Palermo. It was really a wonderful session. It's a new subject to me, this notion of whole person health. It isn't about a separate organ or a system, but it actually incorporates biological, behavioral, environmental, and social domains into the overall assessment of how an intervention may work. She really focused on this concept in recurrent acute pancreatitis and chronic pancreatitis. She wanted to focus on these biological, behavioral, social, and environmental structures and how to investigate things like chronic pain, insomnia, anxiety, depression, and substance abuse. We next jumped in to a talk from one of our NIH leaders, Nancy Diaz-Garandos. I'm sorry, I butchered that name. She's an expert in addiction medicine and really provided a compelling discussion. Turns out alcohol is obviously a major contributor to mortality and health conditions. About 140,000 people die in America a year from alcohol-related causes, including acute injuries while intoxicated. That turns out to be 1 in 10 deaths for the age groups between 20 and 64. As 30% of pancreatitis is alcohol-related, she emphasized to us that these folks, for the most part, are likely to drink again. Recidivism is the norm. It is also associated with shortened life expectancy. Just telling them they need to quit is probably not enough. She helped us with a couple of simple tools. First, she reminded us of this very straightforward tool to diagnose and kind of assess the severity of alcohol use disorder. It's a very low burden instrument to administer. It can be done in literally a couple of minutes. She then dove into the details of the neurobiology behind addiction, driving home that genetics is a significant risk factor, especially when coupled with environmental factors. She brought up subjects that I hadn't thought about, like, for example, an ability to process alcohol actually puts you at risk for alcoholism. She then emphasized this concept of allostasis and how the body adapts, focusing predominantly on how the brain adapts to chronic alcohol exposure and how once you start to deviate from the norm, patients with alcohol use disorder actually drink to try to get back to normal, not to be elated. And often they drink to reduce other symptoms, often which are anxiety, depression, and despair. She had some happy things to finish with, though, which that alcohol use disorder is a manageable disease with treatment options. She talked about cognitive behavioral therapy, family therapy, other things that people are familiar with, like group support, Alcoholics Anonymous, and others that have equal effectiveness, the need for medical management, vocational and recreational rehab, and then on to some pharmacological options like naltrexone, which has been shown to reduce cravings. The next talk was by Diraj Yadav. He talked about measuring pain intensity and frequency, and that there was a need to standardize assessment to determine the need and type of treatment and to monitor temporal changes in response to those treatments. This slide demonstrates how the various instruments that were available prior to their work differed in the various areas that they assessed. He went on to describe the group's efforts that he led, putting together an SF compact tool that comprises of subscores from each pain domain shown here. This assay can be done and our instrument can be applied in about 10 minutes time according to the group, and aligns very well with both hospitalizations and quality of life. It does differ a little bit from a couple of the common pain measurement scores, as one would expect, because it is looking at slightly different domains. But at the end of the day, we have a tested instrument for these studies moving forward as far as assessing the severity of pain. He suggested one way we could do this would to correlate the Compact SF instrument with the PQST studies that are currently going on. An effort that also stated that would be very important is to have a web-based, or better yet, a phone app to actually apply this instrument on a more consistent and regular basis. That closed out the first session, and we moved on to nutritional interventions in pancreatitis. This was started by Dr. Dugan, who visited us all the way from Ireland, and she's done obviously a tremendous amount of work in this field. The first thing she pointed out is that we now actually know what these patients eat, which was something that was unknown previously. She also described that malnutrition is the norm. She got us to get a bit of understanding about how, when alcohol is the etiology, alcohol calories can represent the majority of the calories in that individual's diet. She also described we've got a better understanding of the nutrient deficiencies we would expect. And then really focused on areas where she feels there's gaps in our knowledge: bone health, dietary intake, physical activity, and body composition. And she emphasized that we need core outcome sets to figure out how these all collectively can be measured. She also mentioned that we do not really have an effective global tool for measuring malnutrition. She's focused again once upon multimodal nutritional-based interventions, circling back to the notion of whole body health. This was followed by Dr. Roberts from Ohio State. She really was given the task of how do we design these trials. She emphasized the need for baseline measurement, and again brought the notion that we do not have a high quality instrument to measure nutrition. She also emphasized this concept of food security, the notion that 17% of patients with chronic pancreatitis actually are worried about whether they'll be able to eat enough food. She also emphasized that the current measurements of nutrition carry a requirement of a high level of literacy and therefore can be somewhat challenging to administer. She then forwarded the notion of polyphenols as something of particular interest in her work as a dietary supplement that would hope mitigate the chronic inflammation and reduce potentially fibrosis and progression of the disease. She also mentioned that this happens to be in beer and wine, but chocolate too. Martin Rosenthal then came in and focused, instead of more on chronic pain or relapse, or chronic pancreatitis or relapsing acute pancreatitis, he focused more on nutritional support of a patient suffering from severe pancreatitis. He focused out a couple of opportunities he thought where we could actually intervene: a couple of amino acids like arginine, which is essential for T cell function, leucine, which is essential for anabolic type of performance, and then the notion of omega-3 fatty acids as a source in the diet, which then ultimately can be broken down into resolvins, and the notion that these might have profound anti-inflammatory properties. Jay Freeman then brought to our attention the data from the PAUSE trial, emphasizing that children who are on enzyme replacement therapy appeared to have less frequent episodes of acute pancreatitis, and that they have designing a clinical trial to actually prospectively study if this is in fact real. They're well into this trial, and it is funded. The next session was actual pharmacological or biological interventions for pancreatitis. Sorry, this is sensitive, isn't it? Vikas Dudeja started off this session talking about their studies in pirfenidone, which is an FDA-approved antifibrotic agent for idiopathic pulmonary fibrosis. He stated that if you give this drug, importantly, after the induction of acute pancreatitis using a cerulean model, sometimes even after 72 hours from the insult, the result was reduced edema, necrosis, and inflammation. It also appeared to accelerate recovery. The mechanism has been identified by his lab and appears to be driven by macrophage-generated IL-10. One thing that Dr. Dudeja mentioned was that his animal models are not ideal as they do not really represent a fibrotic replacement of the pancreas. So in studying this molecule as an antifibrotic agent, it's probably not ideal in vivo. He also emphasized that he needs an endpoint for the FDA because we can't measure fibrosis in a human specimen. He said mortality and survival just aren't appropriate and brought up this notion of patient-reported outcome measurements as a key endpoint that the FDA may find appropriate to assess whether the drug has been effective or not. That being said, at this point in time, they're really doing a phase 1 dose escalation study to assess safety and tolerability. Similarly, another target, TLY012, was presented to us by Adam Bell. Similarly, this is an antifibrotic drug. It's really fascinating to me as a fibroblast biologist in that it utilizes a modified trail, which is a death receptor ligand with death receptor 4, and induces apoptosis and SMA producing activated fibroblasts. He demonstrated some effectiveness of the reduction in injury in a cerulean model, and also a rat model that suggested that the molecule would reduce the rat's pain. They have a number of clinical trials that they're in the process of getting activated. It is my impression in listening to Dr. Bell that they haven't chosen which of these 3, but it'll probably be number 1 to begin with. Then Dr. Fogel from Indiana came and talked with us about their trial in lacosamide. He wanted to draw attention to the fact that Fletcher White, his colleague, was the expert in this effort, which I thought was very modest. But this molecule is very interesting in that it actually blocks this NaV1.7 channel so that when an opioid is present, it can actually perhaps reduce excessive activity by the nerve. There have been some trials in neuropathy and trigeminal neuralgia, but they're planning a trial and have actually accrued their first cohort. They have a phase 1 dose escalation trial where they're accruing patients 3 at a time and have gotten 3 through the first study, and now they're going to be able to go up to the next dose. Their primary endpoint is safety and tolerability, and their secondary endpoint will be efficacy. They will need a phase 2 trial is one thing that Evan mentioned before they'll really be able to assess any evidence of efficacy. Nick Zromsky then showed up and gave us an incredible talk about work he had done in a pre-clinical model, once again, a mouse model, looking at adipose-derived stromal cells for the treatment of acute pancreatitis. It appears the mechanism of action of these cells is they actually track to areas of inflammation and then mitigate that inflammation. Using an in vivo model, once again, cerulean, and once again, giving the stem cells after the induction of the injury, they demonstrated a reduction in edema, inflammation, and necrosis. This appeared to be mechanistically driven through a polarization by macrophages within the pancreas towards an M2 phenotype. He also was honest in that the conditioned media from these stem cells seemed to produce a similar effect. And he's hoping to progress towards a safety and feasibility trial in humans. They have a number of unknowns that they still need to work through. Their source of cells were actually adipose cells, but it may be that other cells could be a better source. They do have a way of isolating these cells, but still need to work out a method of delivery. And then again, he mentioned that we're going to need an endpoint such as a PROM to understand whether these are being effective or not. The final session, bioengineering surgical and endoscopic approaches for pancreatitis, was also a great success. Started with Dr. Cote talking about advances in pancreatic endoscopy. He broke his talk into 3 basic areas. First of all, describing the use of US in diagnosis, mentioning one of the flaws of inter-observer variability, especially in minimal change disease, brought up the exciting concept of elastography and forwarded it as a potential objective endpoint for some of these trials that were just mentioned, in part because it can be quite quantitative. He then also went on to talk about the role of EUS and ERCP in drainage of chronic pancreatitis. the challenges we face in patient selection and a likelihood of response to that approach, and forwarded the notion that secretin stimulation, EUS or MRCP may be of value. And then interesting, brought up this TRPV4 channel, which seems to mitigate the pain associated with pressure within the pancreatic duct, or the possibility that perhaps that could become a clinically useful marker. And then finally, he just said, yes, we can do necrosectomy through the scope these days, but we're using tools designed to retrieve polyps, not to actually remove necrotic material. So better tools would be needed for the endoscope. Dr. George Gittes came and talked about chemical pancreatectomy. It's just an absolutely amazing kind of talk that he gave. They serendipitously injected a mouse's pancreatic duct with alcohol, completely unrelated, letting to look for that problem. And Dr. Gittes noticed that the pancreas basically had disappeared in the animal, but the islets persisted. And here's a shot here of a normal pancreas. The arrow's pointing to where the pancreas used to be, and these small white dots that actually microscopically represent intact islets. He then went on to demonstrate those islets not only are rather preserved, but much of the complex structure involving the veins around them and their ability to secrete insulin directly into the circulation is preserved, and that they're actually observing that perhaps it's enhancing overall islet function. They've now progressed this through non-human primate studies, demonstrating that the monkeys tolerate it just fine, and they're seeing the same observation. They have also demonstrated that after inducing pancreatitis using a cerulean model, that they can once again, after that pancreatitis has been induced, perform a chemical pancreatectomy with similar results. We then had two talks from surgeons, first from Bill Nealon, who really did a nice job of reminding us that we have actually done a lot of study about surgery in chronic pancreatitis. He also wanted to emphasize we've compared surgery to endoscopy. He brought us back and looked at a couple of studies that compared Whipple to Pusteaux, Whipple to Fry, Fry to Pusteaux, and then surgery compared to endoscopy. There's also trials discussing timing. One of the biggest points he brought up is that there is a lack of surgeons that are trained in the surgery of chronic pancreatitis, leading the preponderance of the operations to be Whipples or resections as opposed to drainage procedures, despite this data, which is quite compelling in that the Fry or the Beggar procedure are associated with lower morbidity and better overall outcomes. The session was then finished, and actually the workshop kind of closed out with Dr. Neoptolemus following up with how do we design surgical intervention trials in pancreatitis moving forward. And John really emphasized the fact the biggest frustration in trying to design these trials is a lack of good staging of early chronic pancreatitis, leading to a very heterogeneous group with different etiologies being assigned to narrow therapeutic options. Just a couple small points that he also brought up that Dr. Neal had brought up. We do know that surgery should ensue within 3 years of the onset of chronic pain with chronic pancreatitis, and ideally before there's more than 5 endoscopic sessions. That summarized all the things that were discussed. So I put together these general recommendations. As I said, these are my first try at this. These will be worked over by those that contributed. But first of all, it became a couple of things that we heard over and over again. These online-based app data measurements on the bottom left, clearly, Dr. Dugan, for example, has a homegrown one in Ireland that they're very positive about. This clearly could overcome some nutrition study endpoints. It might be able to overcome healthcare disparity problems. It was also brought up that behavioral therapy has a real limitation to access, and that just gets augmented in patients who are impoverished or of low literacy, and that virtual behavioral therapy it works, and it's a good thing. It could perhaps open this therapy to a lot more patients. PROMs, as we've talked about through my presentation, keep showing up, and I think will be a good chunk of what the rest of the day will be. The notion that we need to create a measurement of nutritional status equivalent to what was been done with COMPAT, and then a number of trials that were recommended. and not only PROMs, but FDA-approved PROMs. We are a long ways from understanding when we should intervene endoscopically or surgically. So I've put that as we still need to do trials there. And then finally, holy smokes, a chemical pancreatectomy. So I appreciate your attention. Again, I apologize to the presenters from the workshop. I hope I've gotten this done quickly enough and haven't lulled people off to sleep. And I don't know, Dana, if you want me to answer any questions, I'd be happy to do my best.
Why don't we save those questions for the panel discussion at the end of the session, if that's all right with you? Thank you very much, Dr. Hughes. Next, continuing on this theme, we're going to hear from Dr. Diraj Yadav from the University of Pittsburgh, no stranger to you all, who's going to be discussing the outcomes of interest for clinical trials, building on the discussion of the needs going forward. Dr. Yadav.
Thank you, Dana, and good afternoon, everyone. So as Dana in his introduction to the session mentioned, that this is an ongoing discussion in our pursuit towards developing clinical trials. And one aspect of this is what are the outcomes of interest that we need to think about. Now, my job is a little bit easier in the sense that I'm not asked to provide those outcomes of interest and type what to use, but kind of review as to what are the potential ones to consider. And later on in the session, Lola is going to discuss the efforts of Mission Cure to help us to get there. So these are my disclosures, which are not related to the presentation today. So before I discuss about the outcomes, there are some general considerations that we may need to think about for clinical trials in patients with RAP and CP. And the first is, which are the patients to study? And we have during the course of the conference, there are discussions in terms of heterogeneity of both RAP and CP, although they lie in a continuum, but individually also these diseases are very heterogeneous. Secondly, patients with chronic pancreatitis, their symptoms can overlap or coexist with earlier stages of disease. And a couple of examples of this would be abdominal pain. So patients who have RAP, a subset of them may have abdominal pain even chronically. Or there may be symptoms that may be completely unrelated to chronic pancreatitis. For example, diabetes in a patient with chronic pancreatitis does not always mean that this is related to chronic pancreatitis. The other thing to consider is which are the disease manifestations to focus on. Is it symptoms that we need to focus on? Is it quality of life? Or it is the clinical course of the disease? What are the type of studies that we are thinking about? So the outcomes of interest may be very different if you're thinking of a pilot study where surrogate outcomes may also serve as a primary outcome of interest, and hard outcomes could be secondary outcomes. But if you're looking for a more definitive trial, there the hard outcomes become more important. And then what is the intervention of interest? For example, if you have an intervention like surgery or endoscopic therapy, both recruitment as well as retention in these studies could be very challenging. So from a patient and caregiver perspective, and we had a great testimony from Adriana a couple of days ago from the patient standpoint in terms of what are the outcomes of interest from their perspective. And this is a survey that Mission Cure did a few years ago, where the top three issues of interest or symptoms of interest, abdominal pain was number one, nausea was number two, and fatigue was number three. The pain component here is likely a composite, both in terms of the general pain that patients experience on a day-to-day basis, but also flare-ups that occur in a subset of times they get admitted to the hospital for these flare-ups, either for an attack of acute pancreatitis or just severe pain. When patients and caregivers were asked in terms of what are the things that you would like the FDA to know, the most important was the lack of treatment. The second was the burden of symptoms and the impact it has on quality of life and life in general. The third was more of an education gap in the sense that healthcare professionals may not understand very well in terms of what they are going through and how best to help them. And then more research is needed. And the results from the NPF effort in this area in terms of the Voice of Patient report were very similar in terms of the three most important symptoms of interest to patients. And also when they were asked in terms of what aspects of life are most affected, it was the social participation and interactions that were considered to be most important. Now, if you look at it from empiric studies in terms of the burden of abdominal pain, and we have discussed that abdominal pain is the most common symptom. About half of the patients have constant pain, but there are a couple of things that I want to mention here from a trial standpoint. And these are data from the PROCEED study. So if you ask patients, did you have pain in the past 7 days? 60% of patients would say that they had pain. And the reason I bring it up is that within this 60%, again, there is going to be a spectrum of patients who may have mild or moderate pain, and a subset may have constant pain. Some of them may have constant, some may have intermittent pain. And when we think about eligibility criteria for clinical trials, this becomes very important because often it becomes very difficult then to enroll patients in clinical trials because as soon as we see eligibility, inclusion criteria and exclusion criteria, the number of patients starts going down. So the point that I'm trying to make here is that we have to be very cognizant in terms of what is the expected number of patients that will fit into the clinical trial. And if we make the trial too restrictive, then it will become challenging for us to enroll patients. The other thing that I wanted to highlight here is that in addition to abdominal pain, there are also other aspects that may be equally important or maybe even more important in terms of how patients will respond to treatments. And these are data, and that has been shown in other studies too, that patients with chronic pancreatitis who have pain, there is a strong association with psychological and behavioral comorbidities. They have significant impairment of sleep. And Tanya Palermo very nicely actually illustrated that in the workshop and the importance of this. We are not talking about causal effect in the sense that pain is causing psychological comorbidities. We are looking for co-prevalent. So they are prevalent with each other. And the importance here is that if we only address abdominal pain and we do not address psychological comorbidities, patients may not have adequate improvement. So we may have to think about ways in which we can address more than one aspect of their symptoms for better outcomes. Now, in terms of challenges for patient-reported outcomes, we discussed about this in the workshop also. We do not have a good way for a pain assessment tool, for example. The Compet SF actually is a great development in the area, in the sense that it has been developed, it has been validated, it has been shown to be reliable, but now it should be considered for use in other patient populations or different patient populations for validation. We also have few data in terms of if you have a group of patients, for example, the Dutch study very nicely showed that if you follow patients over 4, 5, 6 years or longer, there is change in terms of pain patterns. But what happens to patients over 2 weeks or 3 weeks or 4 weeks or 6 weeks? That's important because we need to know what is the expected variability in the symptoms of patients, because that would allow us to know how much we can impact on that in terms of understanding whether the medication is helpful or not. The other thing which was brought up was placebo response. We have very little data in terms of placebo response in patients with chronic pancreatitis. There is plenty of data in other painful conditions where the placebo response could be as high as 40 to 50%. There was one meta-analysis that was published about 10 years ago with 6 or 7 studies, but the duration of treatment in those studies ranged from 1 week to 4 weeks. So very difficult for you to make any sense. But in those studies, the estimate was 20% placebo response rate. But a more recent study that Phil Hart led for Camostat internationally, the placebo rate was almost 50%. So that's a very important thing for us to consider in terms of what you are expecting the treatment to do. Now, when we move on to disease-related manifestations, these can be a long list of manifestations. So it could be healthcare utilization in terms of attacks of acute pancreatitis, hospitalizations, visits to the emergency room. It could be functional abnormalities, diabetes, exocrine insufficiency, need for endoscopic therapy, surgery, and so on. And I'll use this slide to try to illustrate what I'm trying to get at. This is actually a hypothetical set of patients and their longitudinal course. And I have intentionally populated the outcomes here to enrich this group. But the important thing to remember is if you have a group of 100 patients with recurrent acute pancreatitis and you follow them for a year, only about 15% of them would have another attack of acute pancreatitis. If you're going to look at recurrent acute pancreatitis in these patients, then you have to follow them even longer for them to have multiple attacks, or much lower fraction would have that. If you want to look at, say, diabetes, the risk of diabetes in patients with established chronic pancreatitis is about 5% per year. If you're going to look at patients with RAP, the risk is going to be 3%. Now, this risk is above or the expected in the general population, which is about 1%, but still the rate is so low. The point here is that each of these individual outcomes of interest are so infrequent that it is impossible for us to do a study where you have one outcome of interest as your primary outcome, because we'll never be able to finish the study because we'll need very, very large number of patients. So the point here is that we may need to think about possibility of some sort of a composite outcome where we are looking at multiple outcomes and how they interact with each other. And what I mean by that is that there is a competing risk between these outcomes. So say, for an example, if a patient develops exocrine insufficiency, that patient's risk of a subsequent attack of acute pancreatitis may be very different than a patient who does not have exocrine insufficiency, or say diabetes and so on. So the challenges in disease-related manifestations is that individual outcomes of interest are infrequent. They need longer observation time. At this time, we have limited understanding in terms of what can we expect in a group of patients in the short or intermediate term that is of interest to us, at the most maybe 1 year, 2 years, or 3 years. Because if we have that sense, then we can actually get a better idea in terms of what we can plan and what we can expect in terms of the effect size that we are looking at. And I did touch upon the competing risk, the importance of competing risk in terms of outcomes. Now, there are a number of studies that are ongoing, which will allow us in the near future to get some of this information. And I'll just illustrate 2 or 3 studies in the US, but I know internationally there are studies going on. For example, the PROCEED study, and this exactly the same thing could be applied to the INSPIRE study in pediatric patients. These are studies where there is detailed phenotyping of patients at baseline. And now these cohorts are actually mature enough that we can start looking at intermediate, short and intermediate term outcomes in these patients. We recently enrolled our 1,800th patient in the PROCEED study and reached our target sample size for acute and recurrent acute pancreatitis as well as chronic pancreatitis that was proposed. The other example is the SHARP trial. Now, this is a trial where we are looking at a very specific subgroup of patients with recurrent acute pancreatitis who also have pancreas divisum. But these patients are very carefully being followed, although the primary outcome of interest is whether ERCP and minor sphincterotomy would reduce the risk of subsequent attack or attacks. But we are collecting information in these patients for several other things. So we will be able to understand the outcomes that would occur in this population over a short and intermediate term, and also a lot of patient-related outcomes or reported outcomes, sorry. Another example is a study that is funded by the DoD called Access AP, which is a select group of patients with acute and recurrent acute pancreatitis with alcohol etiology. These patients are also being followed, and we will be able to understand as to what happens during natural course of these patients, and also to understand in terms of whether they had behavior modification or not in terms of referral for alcohol rehab. Did they complete it or not? Did they get treatment or not? So that's going to be helpful. So this is my last slide. What I would like to say is that, yes, we want to get to a stage where we have an ideal instrument and we have an ideal outcome of interest, but we may not get there until we try for a certain amount of time. I clearly remember, and senior members may remember, that about 35 years ago, the inflammatory bowel disease community started with the Crohn's disease activity index. If you talk to IBD researchers now, they'll say, oh my God, we will never use that. But they had to start somewhere. We have to start somewhere, because we can have discussions for the next 10 years and we'll still be here. But I guess if we design something, we test it, the most important thing that's going to happen is we are going to be able to learn whether did we do it right or not, and what would be a better way to design the next trial. So in that way, I think the most important thing for us is to develop a core outcome set, which is ideally developed with feedback from all parties of interest or stakeholders, including providers, patients, and caregivers. It should span across the disease spectrum and also ages, and has components that are mandatory, optional, and only for research. Ideally, it should be used for all clinical trials and possibly observational studies, and then it can be refined over time as we learn from them. So thank you very much for your attention.
Thank you, Dr. Yadav. So one of the challenges in the goal of developing medical therapies for pancreatitis is the challenge of new drug development. We've got all of these brilliant basic scientists who are identifying strategic, actionable pathways, which may then convert into pharmacological agents. And that in itself is a very long path. And so many people have asked the simple question, why not look at already FDA-approved agents that have been approved for similar diseases in other organs and see if they work in pancreatic disease. And our next speaker is Dr. Srikanth Iyer, who is a co-investigator with Dr. Dudeja, who is in the process of, as you heard Dr. Hughes summarize, really moving the studies of pirfenidone, which is a drug which has been approved for idiopathic pulmonary fibrosis, to see if it can be an effective medication in the treatment of pancreatitis. And as Dr. Iyer will tell you, that journey has had some interesting challenges along the way. Dr. Iyer.
Thank you, Dr. Anderson. This talk is going to be a continuation of the talk that Dr. Dudeja gave at the NIDDK workshop a couple of days back, with more details on our experience of taking pirfenidone from bench to bedside for the treatment of acute pancreatitis. And also more about our interactions with FDA that happened for bringing this into clinical trials. I'll skip this introduction slide, just that we know there is no specific cure available for pirfenidone as yet. So as we know, most AP cases resolve by itself without any therapeutic intervention. However, around 20% of the AP cases progress to a moderately severe or more severe form of acute pancreatitis. And it is these patients who are at a very high risk of mortality or morbidity, sometimes accounting for even 50% in case of SAP. And hence, it is in this population that there is an urgent need for developing novel therapeutic strategies. And however, even after decades of research, still there is no specific cure available. And there are a number of reasons for that. One of that is our incomplete understanding of the pathophysiology of the disease. And again, there are inadequate animal models that I would explain in the next slide. There is, again, an inappropriate use of animal models. So when a patient presents to the hospital, patient with AP presents to the hospital, the patient is already in the later systemic phase of the disease. However, most of the preclinical studies that have been successful and on whom the clinical trials have been conducted, in those studies, the drug has been administered either prophylactically or at the very early stages of the induction of injury. And even though they may be successful in preclinical studies, they may not accurately represent the clinical scenario, and which could explain the failure of the clinical trials. And the more reasons include inadequate funding as well as low frequency of events of interest. As I said, only 20% of the patients with acute pancreatitis actually require a therapeutic intervention. So animal models are a very important tool for preclinical studies in knowing the pathogenesis as well as the progress of the disease. And these are the features of, these are the ideal characteristics of an ideal animal model. The most important being it should resemble the human disease in the 4 aspects of etiology, pathophysiology, histology, and the progress of the disease. Unfortunately, there are no animal models to date which can accurately represent all these 4 scenarios. Hence, it is very important that all the preclinical studies must be conducted in more than 1 or multiple animal models to see that the drug actually works in all the models. Now, coming to why pirfenidone. So we at Dr. Dudeja's lab, we work on repurposing of drugs where we select drugs which have shown anti-fibrotic and anti-inflammatory efficacy against various diseases, and also those which are FDA approved, so that the translational of that drug becomes easier. And in this regard, pirfenidone is an FDA-approved drug indicated for the treatment of idiopathic pulmonary fibrosis. However, it has also shown high anti-inflammatory and anti-fibrotic action against other diseases like liver and kidney fibrosis. And as seen in this study, we usually use very severe models of acute as well as chronic pancreatitis. Here again, we have used a 2-day cerulean AP model where the drug was started at 9th hour. It's not started prophylactically, it started at the 9th hour where the injury is already at the peak and it has already spilled into the systemic phase. And here we see a good improvement in histology in the pirfenidone treated group. And also there is a reduction in all the scores, including the edema, necrosis, and inflammatory score. The immune infiltration within the pancreas also shows a drastic reduction in the pirfenidone treated group, as seen by coronin staining, which is a pan-immune marker. And the pancreatic neutrophil infiltration, as evaluated by the pancreatic MPO levels, also show a drastic reduction. So as I said, in this severe model of cerulean AP, the disease has already spilled into the systemic phase, and then other organs such as lungs also shows injury in this model. And as expected with pirfenidone treatment, we could see a very good improvement in the lung histology as well as lung immune infiltration. Again, the serum markers which are known to be elevated in AP, such as the HMGB1 levels as well as CRP, they also show a reduction with pirfenidone treatment. As I said, just showing that the drug is effective in one model may not be sufficient, and we need to use multiple models, and hence we used an even more severe model of AP, which is induced by L-arginine. And here we see that almost the pancreas is totally lost in the AP group at 72 hours after induction of AP, whereas in the perfenidone group, there is a tremendous recovery as seen in the histology of pancreas as well as the lungs. And again, there is reduction in the immune infiltrate as seen by coronary staining. Then we also looked at the kinetics of recovery by starting the drug even later with the drug here. In the previous experiment, the drug was started like at 36 hours after induction. Here it was started even later at 72 hours. So basically we are trying to start the drug even later so that the injury is already in the systemic phase that could accurately represent clinical scenarios. And here, by 120 hours, we see a significant, that is just 48 hours after administration of perfenidone, we see a significant recovery in the pancreatic histology. And in order to find the mechanism, we wanted to find the mechanism of the action of perfenidone. So we chose a time point where the histology, the recovery in histology is not evident. Like we chose a time point which is 110 hours where the histology does not show an improvement. And then we looked at all the inflammatory markers and we found that it was, although none of the markers showed a significant reduction in the perfenidone treated group, it was just the IL-10 which showed a significant increase, which is an anti-inflammatory cytokine. And it does make sense because it may, because it's an inflammatory disease and IL-10 is an anti-inflammatory cytokine. And this IL-10 was found specifically in the macrophages. And in order to validate this finding, we used IL-10 neutralizing antibodies, and we found that the effect of perfenidone was lost. So perfenidone acts in improving the pancreatic histology mediated by IL-10. And again, since this was IL-10 specifically secreted by the macrophages, we also depleted macrophages in our experiment using clodronate. And we found that in the absence of macrophages, again, the effect of perfenidone is lost. So now having established that perfenidone is anti-inflammatory and it shows efficacy against acute pancreatitis in multiple animal models, we wanted to take it into clinical trials. This study was funded by the Department of Defense. This is the clinical trial design in which this is a randomized placebo-controlled pilot clinical trial, and it is multi-institutional with a collaboration between UAB and Mayo Clinic Rochester. And there would be 60 patients, 30 in each arm over a period of 2 years. And the drug is perfenidone, 267 mg oral TID. The primary objectives of this trial includes determining the safety and tolerability of perfenidone in patients of AP, as well as determining the efficacy of perfenidone treatment in reducing the laboratory markers of inflammation, and to check whether it is able to improve patient-reported outcomes. And this is one of the first study to include patient-reported outcomes in the primary and as the primary objective. Although the patient, although the population size is low, that is 30 per group, so this trial is not sufficiently powered to look at the efficacy of perfenidone in curing acute pancreatitis, but still we have included that as a secondary objective, and also to develop a predictive biomarker to check for perfenidone efficacy. The primary endpoints include starting and completing the planned drug treatment, to check for development of anticipated or unanticipated adverse events, to evaluate whether there is a decrease in the PAN-PROMIS score by at least 10 points after 72 hours of starting the drug, and to monitor changes in inflammatory cytokines such as C-reactive protein, TNF-alpha, IL-6, 8, 10, and angiopoietin 2 in the serum levels. This study is embedded with comprehensive list of secondary endpoints, which was even more increased after our long and fruitful discussion with FDA, who suggested including more secondary endpoints to make this study more effective. And some of them include determining the changes in cumulative PANSS score at the time of admission, and as well as the PASS score at the time of admission and at the time of discharge, and whether the patient enrolled in the trial needs shifts to ICU and development of organ failure and so on. The inclusion criteria for this trial is any patient between the age of 18 to 85 years who have been diagnosed with acute pancreatitis. And the most important part is this patient has to be identified, approached, and consented for drug or placebo treatment within 48 hours of diagnosis. And as I said previously, we don't want to risk the 80% of patients with mild AP who can recover on their own with the side effects of pirfenidone. So we would be including only those 20% of the patients who are predicted to have moderately severe or severe AP. And the parameters that we have included to detect that, to predict that are the Pache-2 score more than 8, the Glasgow or the IMRI score more than 3, a CRP level more than 150, the PASS score more than 140 at the time of admission, and the CT or MRI imaging scans suggesting pancreatic or peripancreatic necrosis. The exclusion criteria was again, we had an elaborate list of exclusion criteria, which was even further increased after our discussion with FDA, because we did not want, the safety was the primary objective of this trial, and hence we included even more exclusion criteria, which I will be talking in the next couple of slides. So the exclusion includes patients with ongoing AP or diagnosis of AP in the past 30 days, patients with chronic pancreatitis, and also patients who are at a risk of risk for the use of pirfenidone drug because of its side effects. We did face a number of challenges, and FDA also had some concerns, and then we were able to reach solutions for those. So one of the primary concerns of FDA was whether in the narrow range of patients that we are including, whether we would be able to find enough adequate number of patients. So as I mentioned, this is a multi-center trial, multi-institutional trial. University of Alabama is placed at the catchment area of UAB is really high with patients from the neighboring states, such as Mississippi and Northern Alabama. They all come to UAB. And Mayo Clinic also has prior experience with conducting 2 such clinical trials in AP. So we do not now expect a problem with this. The next concern was whether we would be able to identify patients early on in the 48 hours after admission, because that was one of our inclusion criteria. And for that, we have leveraged the EMR to identify patients who have elevated amylase or lipase levels, and with the CT or MRI scan suggestive of acute pancreatitis. And we have clinical research coordinators who are round the clock, who would be present round the clock to identify patients and get their consent. This was one of the major concerns of FDA about how accurate the prediction would be for patients who develop the severe form of disease. And although there is, we all know that there is no single criteria which can accurately predict that a patient would develop a severe form of the disease. But then we have included and also we have included some new criteria in addition to the existing ones, like the PASS score of more than 140 at the time of admission. So although these criteria and the combination of this, the sensitivity is very high, but the specificity is still low, between 50 to 60% of accurately predicting. But unfortunately, there is no other way of giving a more accurate prediction. And then FDA also had additional concerns, mainly on the safety of the trial. So our exclusion criteria already had patients who are admitted to ICU, but then so later on, we also included patients who are not in ICU previously, but during the course of pirfenidone treatment, if they get admitted to ICU, then we would be stopping the treatment. And also we had initially included administering crushed pirfenidone tablets to people to patients with NG tubes. But then since that is not the standard method of administering pirfenidone, that was excluded. And then pirfenidone in IPF is usually there's a weekly dose escalation from 267 mg oral TID for 1 week, and then later on it becomes 2 tablets TID. But then since our whole regimen is for just 7 days, we had suggested a faster escalation time, but then that was, since that is not the standard for pirfenidone treatment, that was not approved by FDA. And then also there was a concern between pirfenidone itself has some side effects which overlap with that of the side effects of AP, such as nausea, vomiting, and abdominal pain. But then we were able to resolve that by including other criteria for detection of AP-related symptoms, such as scans and all. So that was eventually approved by FDA. And the last concern that FDA had was if the patient is discharged early, and like the treatment regimen for pirfenidone is 7 days, but if the patient is discharged early, then the initial plan was to advise the patient to take pirfenidone at home. But then since we would not be able to monitor those patients for their adverse effects, this was eventually scrapped off. So the treatment would stop the moment the patient is discharged. So the current status of this trial is that everything is actually set in place. It just happened this week. And then we are expecting to start recruitment of the patients from next week. And we also published that pirfenidone is effective against RAP as well as CP, which are fibrotic diseases. And again, we have a clinical trial funded by DOD for testing pirfenidone against CP. And we are currently in the design phase of this trial. This is our group. Thank you.
Thank you, Dr. Iyer. So that example illustrated some of the challenges of trying to identify the appropriate outcome measures that need to be identified for interventional and clinical trials. And the importance of having uniformly agreed upon outcome measures has been emphasized to us by representatives from the Food and Drug Administration for the past couple of workshops that we've been holding related to clinical trials. And this has prompted Mission Cure to take on the challenge of helping us to identify these important patient-related outcomes as they might be included in essentially any or all trials of drug candidates. And here to tell us about the progress that's been made in that area is Dr. Lola Rahib from Mission Cure, who's going to describe the efforts that they have undertaken.
Thank you, Dina. Thank you to the organizers for giving us the opportunity to present our work. The title of my presentation is Core Outcomes Assessment for Clinical Trials in Recurrent Acute and Chronic Pancreatitis. For those of you who are not familiar with Mission Cure is a nonprofit organization that was founded in 2017 by Megan Golden and her brother, Eric Golden, who suffers from chronic pancreatitis, and Linda Martin, whose daughter, Amy, also suffers from the disease. So as Dina mentioned, last year, and for many years, I'm sure, there's been a lot of talk about needing to come up with some core outcome sets so that they can be used in clinical trials. And last year at Pancreas Fest, Tanya Palermo presented on core outcomes for pain in children. And we kind of put things together and thought, hey, let's reach out to her and see how we can do this. And so we did, and we took her approach and we developed core outcome sets for recurrent acute and chronic pancreatitis. Okay, so we established 3 specific aims. Aim 1 is to identify clinically meaningful outcomes from patients and providers to be measured in clinical trials. And Aim 1 was actually approved as an ancillary study from the CPDPC. Aim 2 is to identify the specific measurements to be used based on the domains from Aim 1. And Aim 3 is to qualify the core outcome assessments through the FDA qualification program. The FDA qualification program is an 18 months program, and it allows the qualifications of the instruments for our specific population. And once the instruments are qualified, they can be used in IND submissions, and the FDA wouldn't have to review them again. So we use the OMERACT framework. OMERACT is outcome measures in rheumatology, and it supports the development of core outcome sets, identifying patient and disease relevant domains with corresponding instruments for use in clinical trials, including regulatory approval of new treatments. And the reason we used this framework is because of its rigorous methodology, inclusion of patients early on in the process, and there has been multiple applications with peer-reviewed publications. Oops, sorry. So the steps to using this framework is basically to, okay, I'm trying to, it's not working, okay. Is to generate the domains, agreeing on the domains through multiple stakeholders and voting on the domains by a group of experts. Additionally, it requires the domains to be placed in the OMERACT framework, which is an onion, like an onion. And within the onion, we have oops, oh gosh, I'm sorry. Sorry, I'm trying to point, but it's not. Oh, here we go. Okay. Oops. Wow, that is really sensitive. Okay, so the inner layer of the onion represents mandatory domains, including mandatory in all trials and mandatory in specific circumstances. The middle layer is important but optional domains, and the outer layer is research agenda domains. Additionally, domains are placed into core areas for, sorry about that. The domains are placed into core areas, including death, life impact, resource use and economical impact, and pathophysiological manifestations. And this is to ensure that the domains have adequate coverage. So this is the overall process that we used, the steps in the overall process. And the first step is to distribute the surveys and to have the committee come to a consensus on the final domains. The committee was formed prior to administration of the survey, and it included 3 pediatric providers, 4 adult providers, and Tanya Palermo and myself. Once the domains are once there's consensus on the final domains, then we will specify the measurements to be used for the domains. And then the last step is the last but longer step is the FDA qualification. So, so this is the survey process that we used. We used a 2-round Delphi study, and pediatric and adult providers, adults and parents and children all completed the round 1 and round 2 of the survey. Round 1 was open questions to identify the domains. We then completed qualitative analysis to generate the different domains that were agreed upon by the committee for round 2. And round 2 was closed questions to identify rankings of importance. We then did the analysis from round 2 and had 2 committee meetings for voting and categorization of the domains. 3 questions were asked to the patients, and if they answered yes, then they were prompted to describe their experience in an open text format. The 3 questions were if they felt that the treatment had been working for them or has been helpful. The second question was if they felt that the treatment should have been changed because they were not improving. And the third question was what worried them about their treatment. The providers were asked to list up to 10 patient outcomes that they found clinically most important in treating patients, and to list up to 10 harmful outcomes that they considered important in recommending changing patients' treatment. Recruitment of adults and parents of children 5 years and older was done through the Mission Cure mailing list and social media. Parents of children 12 years and older who completed round 1 were provided with an additional child-specific survey to have their children complete the survey. And healthcare providers were recruited through the CPDPC adult and pediatric working groups. We also utilized the Mission Cure mailing list, and we collaborated with CAPER as well to try to get more providers to participate. The study was approved by the WCG IRB, which is formerly the Western IRB, and participants were provided a link to the survey through REDCap. So we, sorry about that. We had 25 pediatric providers, 20 adult providers, 109 adults, 50 parents and children complete round 1 of the survey. And then we had 17 pediatric providers, 9 adult providers, 83 adults, 68 adults, 23 parents and children complete round 2 of the survey. We had some dropouts, but we think we got a pretty good participation. So after we had round 1 completed, we took the open text questions and did content analysis in order to generate these domains. The domains were agreed upon by the committee, and they were defined as well by the committee. So we have definitions for each domains, and these are the domains that were agreed upon to go to round 2 for voting and scoring. And they were pain severity, opioid use, pain treatment satisfaction, ability to participate in social roles and activities, hospitalizations and ER visits, acute pancreatitis attacks or flare-ups, nutrition, weight, and or growth, disease progression, mental health, diabetes, ability to eat, nausea and vomiting, and stigma. So for round 2, participants were asked to score the importance of each domain from 1 to 10, and to select the 5 most important domains and rank them from 1 to 5. Pain severity was the #1 most important domain among all stakeholders. There was consistency between stakeholder groups. This graph shows the ranking of the domains by the stakeholder group. And as you can maybe see or not, the y-axis is reversed. So anything above this dotted line was ranked as important to that stakeholder. And we have pain severity, pain severity, acute pancreatitis attack, disease progression, participation in social roles and activities, and pain treatment satisfaction were all voted important by at least 3 stakeholder groups. Adult and pediatric providers also rated hospitalization as highly important, and only pediatric providers rated opioid use as important, and ability to eat was only rated important by adult providers. We also set a consensus criteria so that domains with importance scores of greater than 7 by at least 70% of the participants, and scores of 1 to 2 from no more than 20% of the participants were the domains that were included. And they had to be, the criteria had to be met by at least 3 of the stakeholder groups. And this here are box plots showing the distribution of the different domains by the different groups. And the one thing I want to point out is that for the providers, the distribution is a little bit tighter than what it was for the patients. Oops, sorry. So there were 3 domains that did not meet the criteria of the 3 stakeholders having to meet the criteria, and those were nausea and vomiting, stigma, and opioid use. And this is important because this determined how they were categorized into the OMER framework, the onion. And that's what I'm going to talk about next. So once the surveys were completed, then the committee got together again to vote, to do the final voting and to categorize the domains. So again, this is the onion, and the committee put the domains, categorized them into the onion, where pain severity, ability to participate in social roles and activities, pancreatitis-related hospitalizations and ER visits, acute pancreatitis attacks or flare-ups were all mandatory domains and mandatory in all trials. Nutrition and EPI, pain treatment satisfaction, and disease sequela was in mandatory in specific circumstances. Diabetes management, opioids use, mental health, ability to eat fell into the important but optional category. Stigma and nausea and vomiting were categorized into research agenda domains. The committee also added 3 domains in the research agenda: biomarker development, cancer prevention, and cost of care. So we placed the domains into the core areas of the OMER framework to make sure that there is coverage in each area. And we clearly did see that there is coverage in this area, and we agreed that this was okay and that we can go ahead with it. So in summary, core outcome domains for recurrent acute and chronic pancreatitis were developed through stakeholder and expert input. We used a 2-round Delphi poll to do this, and a committee of expert expert providers reached consensus on outcome domains using the OMER framework. There was consistency between stakeholder groups on most top domains, and the committee fit the domains into the OMER framework with pain severity, ability to participate in social roles and activities, pancreatitis-related hospitalization and ER visits, and acute pancreatitis attacks or flare-ups as mandatory domains in all clinical trials. So the future work is selecting the appropriate measurements to assess each domain. And to do that, we will use PRO experts, patient experience and feedback, and the FDA qualification program. This is really important, and we feel that it serves a valuable tool in enhancing our understanding of the disease and ultimately bringing therapies to patients. And also it ensures that the treatment benefits are meaningful to patients. And in order to utilize these tools in a clinical trial in a very efficient way, we really need to, this has to be done in a collaborative manner across all stakeholders. And we ask that when these tools become available, that you would consider using them in clinical trials. And we are hoping that next year at Pancreas Fest, we will report on the instruments that we will be selecting and the progress on the FDA qualification program. And thank you. So I just want to say that over this last year, it's been such a collaborative effort between the CPDPC working group, the committee, the participants, patients and families and providers. And I think because of this collaboration, we were able to make this progress, and we really are looking forward to how much more we can do next year when we meet. And I would also like to thank the Mission Cure team, specifically Yoon Bing Tan and William Salerno for their contribution as well.
Thank you, Dr. Rahib. So this is obviously an interesting process to use a series of survey tools to assess what physicians and patients think are the critically important outcomes that need to be included. And it's important for us to learn how the FDA views these efforts and what their recommendations and priorities are. And to speak about that, we have Dr. Chris St. Clair from the FDA, who's going to address that topic.
Thank you. Well, I'm a clinical reviewer in the Division of Gastroenterology at FDA, but in a past life, I was deeply involved in PRO development at the FDA. And so this is definitely a topic that's near and dear to my heart in multiple ways. So with that, so I was thinking the best way to spend my time here that would be most informative following some of the great presentations. And so I want to give you a sense of the types of evidence that we generally look for to support use of PROs in clinical trials. And I'll just preface this by saying everything I'm going to go through is explained in much greater detail in FDA guidances, which I'll show at the end. So definitely recommend digging deeper into the topics through the guidances that we've published. The standard disclaimer is that this presentation reflects my views and not necessarily FDA's views, and I have no conflicts of interest. So just before we, get into this, how do we define patient-reported outcomes? So PROs capture relevant signs, symptoms, and impacts of a disease. Obviously, PROs are reported by the patient, but I say this to contrast it with other types of outcome measures like clinician-reported outcomes or caregiver observer-reported outcomes. PROs are unique because, unlike the clinician or the observer measures, the PROs can measure things that only the patient can truly know and truly quantify. So good examples of that are pain intensity and nausea severity. The patient knows how they're feeling. You can't necessarily rate it the same way just by observing the patient. And of course, PROs, importantly, are used to inform endpoints that assess the potential clinical benefit of a proposed therapy. And so do I mean by clinical benefit. So the definition for clinical benefit that we use is a positive, clinically meaningful effect of an intervention, meaning a positive effect on how an individual feels, functions, or survives. In many GI disorders, outcomes like irreversible morbidity or mortality occur infrequently. And so measuring these types of outcomes in a clinical trial is not often feasible because of the extensive duration of time and resources you'd need to actually conduct in power trials like that. And so we look to PROs as primary or co-primary endpoints in a lot of GI drug development programs that are intended to demonstrate clinical benefit of the proposed therapy by focusing on that aspect of how the therapy affects how patients feel and or function. So every drug development program has its own unique considerations, of course, that affect how PROs will be used in that specific program, but there are key principles that generally apply across all of the different programs and indications. So I bring this up because last year, a few of us from the Division of Gastroenterology published a brief article in the American Journal of Gastroenterology that just focuses on the key principles that we think are most applicable across programs and is a good introduction to this topic. Maybe before you dig more deeply into the FDA guidances, we hope that this gives a good overview of the science. So into the types of evidence that support PROs in drug development programs, I heavily emphasize that in terms of evidence, there's a qualitative component and a quantitative component, as well as this component of what do we need to actually interpret PRO data that we gather in clinical trials. So I'll go through these in more detail in the subsequent slides, but the qualitative evidence generally comes from patient interviews or focus groups. But of course, as we saw from the Mission Cure presentation, there are other methodologies like surveys, which I'll also mention briefly and are covered in the FDA guidances. But the key point is that the qualitative evidence is showing that the PRO measures appropriate concepts and that the PRO questionnaire itself is actually understood as intended by patients. So that when it's used in a clinical trial, we're not worried that, oh, was there a bunch of variability in how different people interpreted the questions, the possible responses. We want to sort of rule all of that out early on and have the evidence to know that people have interpreted this appropriately as you intended as an instrument developer, and you can use it in a clinical trial and everyone will know what it means and it actually reflects their disease. The quantitative evidence generally comes from testing the PRO in the clinical trials themselves and performing certain psychometric analyses. So this is sort of the more statistical side of what you look at when you actually use the PRO in a clinical trial. What's really important is the bottom box of interpretation of meaningful change, which stems from the qualitative and the quantitative evidence here. In addition to this qualitative and quantitative evidence to support the PRO itself, we also need information to help us interpret the data that come from using the PRO in the clinical trial. We have to understand what kind of changes in the PRO scores correspond to clinically meaningful improvement in the disease. And we use both qualitative and quantitative methods to address the question of meaningful changes in PRO scores. And so I'll give some examples of that as well. First, the qualitative evidence. So there are kind of multiple parts in this process of gathering the qualitative evidence. I think a key point is that the qualitative evidence is really the foundation of PRO development. And so it's not wise to get into quantitative analyses before the qualitative base is really solid, because without solid qualitative evidence, it's not really clear what you're quantifying, and that can lead to problems later on. So qualitative evidence to support a PRO in a clinical trial usually comes in two different types of interviews, although, like I said, there are other methods such as surveys. As relates to concept elicitation interviews, in most drug development programs, the interviews are kind of the normative method that's used. And they're semi-structured interviews where, a trained interviewer is talking to a patient and letting them describe their disease and how they experience it, on a daily basis, weekly basis, so on, to understand the general concepts that a PRO questionnaire might need to measure for a clinical trial. But these don't necessarily need to be interviews. They often are, but they don't have to be. There are multiple ways of conducting concept elicitation, such as we saw with Mission Cure. They used a survey methodology, which I think is great because the sample size that they got was phenomenal, quite frankly. And, if you get meaningful data and you get a representative sample, it does the job. So I think that's the key point. You kind of maybe adapt the approach you take based on, where the patient population is geographically, what resources you have, so on. It really depends on where you're at. But the FDA patient-focused drug development guidance, number 2, which I'll link to at the end, actually directly compares different methods in terms of the sort of advantages and challenges of each one. So that's something to look at. So after concept elicitation, regardless of the method you use, the next step would be to actually draft the PRO instrument that you might want to use in a clinical trial. And once you have that draft PRO, you need to do a little more qualitative research than to have patients go through your draft PRO in an interview type of format to see what are they thinking when they read the instructions? What are they thinking when they see how the symptoms are described? Do the possible response options they can select actually represent these gradations in, disease severity or frequency in a way that the patient relates to, in a way that the patient understands? And I really really want to emphasize the importance of the cognitive interviews, because it is so important that when you use your PRO in a clinical trial, that you have confidence that everybody is interpreting the questions and the response options the same way. You don't want to risk introducing variability just because of, a wording issue or an ambiguous item. I will also point out that whereas there's a lot of flexibility in how you can do concept elicitation, cognitive interviews, I think, work best in a sort of one-on-one interview setting because it requires the interviewer to do more probing in, if something's ambiguous or a patient doesn't understand something, the interviewer really needs to probe why and then take back to the, developer maybe ways to improve that item. And these are often done remotely, especially in the post-COVID era. I mean, these are most often just Zoom interviews. So I went through a lot of this. No, let's skip the slide here. So, importantly, the concept elicitation part is informing what to measure, but also how to measure it potentially. When it comes to defining the concepts to measure with the questionnaire, it's important to capture the relevant details of how the patient actually experiences the symptoms on, a daily basis, weekly basis, and so on, potentially including natural fluctuations in the signs and symptoms and how, those are affected by external factors, by activities they do, so on. One key decision is, say you have a concept like a symptom, are you going to measure the severity of it or the frequency of it? And that can, really change your approach. So these are just kind of the things you have to think about. Concept elicitation generates a lot of different concepts ranging from the signs and symptoms themselves to quality of life impacts, which can be, obviously a whole range of things. And I think it's important when thinking about how to translate concept elicitation findings into a PRO for clinical trial use, that you remember the conditions that the PRO will be used in a clinical trial might be different than if someone was just, doing a questionnaire in their daily life. Like in a clinical trial, rescue medication may be controlled, or just, the rates may be measured, and you have inclusion exclusion criteria and so on that might actually, sort of change your approach in terms of prioritizing, which things to measure. Another thing I'll point out is that when interviews are conducted, the transcripts of the interviews themselves are evidence that would support the PRO. So it's very important if you, decide to start doing interviews to support PRO development, that they are recorded and transcribed, because that's a powerful piece of evidence that would most likely be reviewed by FDA, but really supports the development of the PRO itself. So the cognitive interviews, of course, this is what you do after you've drafted the PRO. Again, these should also be recorded and transcribed verbatim. The detail and the precise way that patients describe potential issues with PRO is very important sometimes. And of course, appropriate qualitative methods should be used to actually sort of get that information out of the transcripts and turn them into something that informs the PRO itself. And so, if you're going down this path, we recommend submitting the interview protocols and the interviewer guides for our reviews so we can help you make sure that you'll get the most value out of your interviews. So now I'm going to give an overview of the interpretation of meaningful change aspect of this, which is really important in clinical trials. But there's a lot of stuff that stems from this. So I'm just going to give an overview, and I again recommend referring to the FDA guidances on this. But when we interpret the PRO data from the clinical studies, it's important to understand whether the patients experience meaningful clinical benefit, because statistical significance alone doesn't actually tell you whether individual patients experienced meaningful clinical benefit from their perspective. And so there are multiple ways to approach this issue. We recommend both a quantitative approach and a qualitative approach. which I bolded here, anchor-based methods and exit interviews. Anchor-based methods are the quantitative method that's recommended, and exit interviews are a qualitative method that I think work really well. And when used together, again, the qualitative and the quantitative component can paint a much more comprehensive picture of whether patients benefited, and if so, how they benefited from the treatment. So again, really high level, but I just want people to be familiar with the terminology of anchor-based methods, because if you talk to us, we will talk about this quite a bit. Anchor-based methods essentially involve comparing scores from, say, your PRO that you're developing, which measures signs and symptoms. You compare the scores of that to scores from anchor scales, which are these global assessments of disease severity and how patients perceive changes in their disease severity over time. And the anchor scales can inform what magnitude of change in your sign symptom PRO is considered meaningful from the patient perspective, and correlates to a more global change in disease severity. And anchor scales are really important. So we recommend, if you're doing cognitive interviews, to also test your anchor scales. These are general examples of anchor scales. We commonly recommend that both a patient global impression of severity be included, as well as a patient global impression of change. These they're intended to sort of get to the same, address the same question, but in two different ways. And so by having both, you can kind of triangulate the meaningful change threshold in the PRO scores a little more precisely. And so they're very important and very useful when reviewing data from clinical trials. This is not something I have time to discuss in detail, but I just wanted to show these figures because these are empirical cumulative distribution function curves. And when anchor-based methods are done, this is a common graphical output that will show the sort of separation of PRO scores based on the global disease severity. And so, you could see if you have separation between the different levels of disease severity, how that might help you determine where the, at what point the change in the COA score is actually, indicative of a global change in disease severity. Exit interviews, this is, of course, interviewing patients shortly after the end of the treatment period, but before unblinding. Exit interviews are really helpful sometimes because they can allow the patients to provide more detail about their experience during the clinical trial. And sometimes that gives you information that was not captured otherwise. So I think it's wise to plan to conduct interviews in clinical trials ahead of time. Because sometimes you just don't know, what's going to happen during the trial. You might need that information from patients, at the end to sort of tie up loose ends potentially in the data. So I always recommend planning for exit interviews. And this is something to discuss with us before starting the clinical study. So you can just kind of have your method ready to go so that when patients meet the time point, you can just do it. It's just a more efficient way of doing things. There are multiple ways to interact with us at FDA. Of course, in the context of an individual drug development program, an IND, NDA, BLA. But there are other ways that are pre-competitive. So, Lola was talking about the COA qualification process. That's a really useful one to meet with us outside of a specific drug development program and plan out how you're going to do the PRO development and be able to get our advice. There are also other ways more generally to meet with us. There's this thing called critical path innovation meetings, which are also pre-competitive and outside of a drug development program. They're not always COA specific, but that's just another pathway. And there's much more information on those on the website, of course. But regardless of the pathway you choose, if you're, in this field and you're looking to study a drug, recommend talking to us as early as possible through the, channel that is most appropriate for your situation. Even pre-IND, that's a good time to talk to us about your plans. So here are the guidances that everybody should read, as well as a link to the COA qualification program and the publication that I referenced earlier. So thank you for your attention.
Got a mind of its own. So obviously a number of issues. If pain, I'll start with a question. Is Dr. Yadav still here? I don't. Yes. Oh, there you are. Okay. Thanks, dear. I didn't see you at the end. If pain is the leading symptomatic problem for patients, let's say with chronic pancreatitis, and you have a drug trial and you want to solicit the symptomatic response of the patient, from what we hear is it's advisable to also have some sort of a quantitative measure of that primary outcome. And I'm reminded that in cystic fibrosis, for example, when the Cystic Fibrosis Foundation really put their heads together to decide how they wanted to support drug development for cystic fibrosis, they decided that the primary issue was the pulmonary disease, and they had a wonderful test called pulmonary function testing, which was able to quantify the function of the lung. So they would ask patients, how do you feel? Is your breathing better? Et cetera, et cetera. And they had this quantitative measure to combine with the symptoms. So in the area of pain, the question is, what's our quantitative measure for pain?
Yeah, actually, that's a very important question. And I don't think that there is going to be one answer to say that this is it. I think what you are asking is what is the effect size that would be of clinical relevance. And by effect size, what I mean is what is the improvement in pain above and beyond what you observed in the placebo group. And it all depends upon what the intervention is, how difficult the intervention is, what's the tolerance, what are the side effects, and so on. But in general, I would say that some of the initial trials and what I've read in the literature, a 10 to 20% improvement as compared to placebo would be a good effect size to aim for, and especially if we are thinking of a high placebo rate, because then you're actually looking for a much higher effect. So that would be my answer to begin with.
And what tool would you use to quantify pain, to measure pain?
Yeah, so, and that's going to be something maybe next year when we come back, we can tell you. But as of now, and I think the second aim is what is going to be what the committee would choose would be what the measures would be. But if as of today, I believe COMPAT-SF is the only validated measure for this purpose. And I think doing studies, understanding the variability of COMPAT with repeated administration in different populations could give us an idea as to what do you expect in a population of patients during their usual care as to the variability, which I think is something that, and Dr. Lyons can comment on that, is what the FDA is looking for in a population.
Maybe I can comment on it. We'll see.
Push the button. That sounds like you got it.
Get it?
Yeah, I think so, yeah.
No? No.
Yeah.
It's-
No, it doesn't.
Okay, thank you guys. And my sincere gratitude for no.
If you get the microphone closer to you, I think.
Oh, okay. There we go. That's much better. Sorry about that. I just wanted to start by just taking a moment and just expressing our sincere gratitude for this group, because it really has just been a joy over the last several years to be involved and to watch the discussions and just the open spirit of collaboration that exists across advocacy groups, across federal agencies, across researchers and scientists, and all working together toward the common goal of actually having approved therapies for these patients who desperately need it. I know that's not what I was supposed to talk on, but I didn't have a session, so I'm taking a little bit of liberty, and I apologize for that. But before I get to like what we actually want to see, in highlighting that appreciation, again, I was talking to Darwin, I'm from Kentucky. And so you have the triple crown of drug development going on right now. You have a beautiful natural history study that is soon to report. You have both qualitative and psychometric research that is ongoing, that is being driven and really pushed forward by the voices that matter, by the patients themselves, as well as by you in this room who are taking care of these patients. And you have brilliant, innovative scientists studying novel therapeutic targets that may be promising for this disorder. And so although we may seem as FDA that we are kind of, we're the tortoise and you're the hare, really with where you are, you're in the most perfect space to be. And there's so much excitement coming for this condition and coming for this group. The reason that we are cautious is that we want anything that is measured and any patient experience and any patient sacrifice that is given by participating in a clinical trial to mean something at the end. It helps no one if you do an entire study and you end up with uninterpretable data. And that's both the challenge and the blessing of PROs, in that it can be viewed as more subjectivity. It's more of a symptom. We have a highly heterogeneous variable condition with intermittent episodes that may or may not progress. And we have no endpoints that can be assessed in a feasible manner. So where do we go from here? And that's why qualitative and quantitative data and interpretation is so important, as Dr. Sinclair highlighted. It is the aspect by which we transform the experience of the patient into a concept that actually measures how they feel and function so that we can assess it, measure it, study it, reliably obtain an outcome that separates an effect of a treatment from happenstance, from chance occurrence, from placebo effect. And I hope I have gotten into some part of answering your question in that, but I do thank you guys for the liberty, and thanks for letting us be a part of this.
Let's take a question from the audience.
Thanks. This is actually a comment in response to your question, Dana. It's really multiple questions. What should we measure? And that's really in the eye of the beholder, whether that's FDA, patients, or us as academicians. And what I can say is what I've seen from FDA through at least a couple studies that have gone through the drug development pathway, where there's a specific drug, specific indication that's under study within a specific study protocol, is one that we were asked to use for primary assessment of pain was the average daily worst pain intensity score and change compared to baseline. Now, how that outcome was selected was something that I don't have all of the details on. I'm not clear that there was patient input, and also that was protocol and drug specific. In other words, if you were to approach FDA today with a different product, it's possible that the discussion could lead to a different outcome. So I think that's really one of the key values. And Chris really did a good job showing the roadmap of having qualified clinical outcome assessments, is that this whole process doesn't have to be restarted each time, each protocol, each time one of us has something that's promising from preclinical research that we go forward. And so I think it's going to do everyone a service, the FDA, patients, investigators, pharma as well, to really be able to move the field of clinical trials forward. So long comment, but quick question. So we heard earlier today in the context of trying to increase diversity of research participants in clinical trials that one of the recommendations was actually to consider avoiding unnecessarily strict or stringent eligibility criteria. And the example that was provided in this session, it seemed like the direction was in the complete opposite, that it was not towards optimizing inclusion, as that speaker said, and it was more towards a more stringent approach. So I'm curious if you could maybe share a little bit more, both from the FDA as well as from the investigator side, what sort of things go on in those conversations when, you know, eligibility criteria being asked to tighten up, be more strict, but we're all wanting to, you know, enroll and recruit more diverse study populations. So it's actually, you know, maybe if we could hear from both sides on that.
All right, I'll go ahead and start because I already have a hot mic. Okay, so just to respond to your comment there in the metrics in the assessment of pain. So with that, I hope they gathered the patient experience and whatever outcome they were assessing, whatever condition, because pain is not something that everyone experiences in the same way. And certainly we know that patients with pancreatitis get sensitized to pain and desensitized to pain in very different ways. They have a high acute perception of pain. However, they're also used to living with pain. And so really any information independent of how your patient is experiencing it or how the patients with the disorder experience it, you really can't interpret that. So I hope that that was there. Pain, there's no doubt that that is crucial and paramount and important to patients with pancreatitis. However, pain in itself, we have drugs that treat pain. Unfortunately, they're not perfect. They're not good. I don't think that anyone in this room would say that that's our goal, right? The goal is to disease modify, mitigate, prevent, cure. So I just wanted to state that real quick. Going back to the example that was provided, and thank you for speaking of your experience, that scenario is also very specific to the drug program. So we want to take all things into context. So, and as it has been discussed, I can comment on it a little bit, that when we get a program and we look at the population that is targeting in terms of a safety assessment, that is your primary goal. When safety is your primary goal and you have a very small sample size, unfortunately, a homogeneous population increases the likelihood that you'll get interpretable data there. When you want to expand it to a more broad application of a long-term therapeutic, you're doing that dance between applicability to the larger intended use population and altering and dimming down the noise so that you can find a signal. And so although it does appear, and you know, we do have a lot to say, sorry, but our comments and our intentions are always within the point of the entire context of the development program. And although we may recommend tightening things for the sake of either interpretability or feasibility, that is never the end goal. The end goal is always to be able to inform the use of the potential product in patients that desperately need it. And that's all of the patients that desperately need it.
Yeah, thank you
Any
for the
other
question.
questions?
And
Go ahead.
oh yeah, sir.
I had a quick comment, but if the speaker wants to comment, I can do that.
Right. So regarding the stringency of the inclusion criteria, we had a very long discussion running into several months with FDA, and it was like we want to emphasize the fact that that was a very smooth and very knowledgeable discussion we had because pirfenidone as such is indicated only for IPF, and we don't know what effect pirfenidone is going to have in patients of AP, where the side effects of pirfenidone itself have some kind of coincidence with, some kind of overlap with the side effect, with the effects of and the severity of AP. So we might not know what is the effect because of pirfenidone, or is it because of the normal course of the disease. And with all these ambiguities, it is like the patients who are volunteering to get enrolled into the clinical trial, we do not want to put them into any undue risk. And the sample size itself was low, and the primary objective was only to to determine the safety and efficacy. If it is not even efficacy, just the safety, whether pirfenidone is actually safe to be given for patients of AP. And with that kind of primary objective, I think we were very much in agreement with the stringency in the inclusion criteria we discussed upon.
But your inclusion criteria are patients with acute pancreatitis who are predicted to have severe disease, but who are able to take PO liquids and are not in the ICU. That sounds to me like a very slim sliver of patients with acute pancreatitis. And I'll bet there was some discussion between the investigators and the FDA in terms of arriving at that agreeable inclusion criteria. And we'll be real curious if you can actually meet your accrual goals with those kinds of constraints. It's hard for us to imagine how many of those patients will actually fall into that.
And it's predicted to develop. That's one thing that's really key. I'm sorry.
Yes.
That's one thing that's really key with this program is that it's patients who are predicted to develop. And pirfenidone in itself is a capsule tablet. You have to swallow it whole. The tolerability of pirfenidone and the side effect profile decreases when you're actually able to take it with food. It's labeled to take with food. So there are some really real constraints. However, I would applaud these investigators for hearing us out, for working together, for collaborating to find a population that they can recruit and accrue that's able to do this initial study for them.
Dr. Conwell. No, turn it on.
Is it on now? Yeah. So my question is really for the surgeons, because one of the things that we know works at early intervention for surgery works, and it's the right operation in the right patient. But one of the things I learned is that, as I've gotten older with this, there are less surgeons that can do the pancreas drainage procedures. A fry procedure in the right patient is very, very effective, but there are very few people that can do a fry anymore. Dr. Neoptolemus can do a fry. He can do a fry, but I'm just curious in your recommendations from the conference, should we be saying something about surgical training? And I don't know what it is right now, but a lot of surgeons can do Whipples. But I don't know what happens in terms of fries and drainage procedures. I just want to hear your comments about that. That's a very effective, surgery works. Surgery works better than endoscopy. We know that. Surgery is very effective. So these patient-reported outcomes are going to be used in those surgical trials, because we all know that if we get them to the surgeon fast enough, it's very effective. It's more of a question.
Just a brief answer. We talked about the comparison trials that have been done in the past. As far as the efficacy of the operation, which operation you, whether it's a resection or drainage procedure, actually leads to fairly equivalent relief of pain and other symptoms. It gets more about the side effects of that various operation. Obviously, the Whipple comes with a higher morbidity than a fry procedure.
I just want to comment some of the points that Aya raised in his study, in addition to those that Dana's already mentioned. You can only have one primary endpoint in a clinical trial. You can't just say we're going to have 20, 30 endpoints, which is what you were doing, because the chances are you're going to have one of those coming out. The FDA won't like that. Nobody likes that. So you can't do that. The second very important point in your study design, you were, I think, I'm not sure if you used the word stratification, but you were obviously wanted to balance out those from the time of diagnosis. That's also a fundamental error, because what you should be doing is from the time of symptoms. I've done about 40 randomized trials at least in my life, but I got a paper in the Lancet on acute pancreatitis, which clearly shows do not pick the time of diagnosis, pick the time of symptom onset, because the time when a patient gets admitted varies enormously depending on where the patients are and what the healthcare system is like at that point. It's extremely important.
Thank you, Dr.
That's just it.
Collins.
I've got other things I could say, but I won't.
I wanted to ask Dr. Rahib a question. You gave us a nice synopsis of the process you went through to identify these consensus-driven primary outcomes. And I may have missed it, but I wasn't sure how they differ between recurrent acute pancreatitis and chronic pancreatitis. I think one of the things that we've heard at this meeting is that we're beginning to realize that the opportunity to really intervene and change the course of disease is if we treat people early on, as Dr. Neoptolemus is telling us, and that we pick on patients who have recurrent acute disease rather than classic chronic calcific fibrotic pancreatitis. And so your survey involved both patients and physicians treating both pediatric and adult patients. How did the outcomes differ from those groups? I didn't quite understand that.
The outcomes from the providers and the patients?
Providers, and how is it different from recurrent acute pancreatitis subjects versus those with chronic pain?
So we did not stratify the data. We included all recurrent acute and chronic pancreatitis, but we can certainly go back and look.
I'll bet that will be important because I suspect that, for example, for pharmacologic clinical trials, the investigators or pharma will want to focus on that form of the disease that is likely reversible or progress can be preventable.
Yeah.
And that means that they'll likely be looking at recurrent acute disease rather than established late phase chronic disease. So that may be the target, that may be the optimum target for example, clinical trials involving drugs. So those are the outcomes, those are the measures that we'll be focusing on.
Yeah, and I agree. I think that's definitely important. And we will definitely consider that when we are working forward, when we're doing the selection process for the instruments.
Can I make a comment about the pain regarding this session? The patient-reported outcomes, as much as they are validated as instruments, and they're very, very important in any study design, we know even when we get a score or a certain scale, it does have subjectivity to it because it's dependent per patient, and the pain complexity, depending on the duration of pain and desensitization, would go all in the patient's interpretation of their symptoms. So while we want to take that into consideration, I really think, especially in the pancreatitis world, as it's a main driver for pain prescriptions, we got to a point where we have to have an objective measure that is not just pancreatitis specific, that is an acute pain marker that you can measure on a scale and quantify, maybe through a protein marker. And I wish Jamie Solomon stayed in the audience, but that is something we really believed in and have worked on, because then it would not be pathophysiologic just to the pancreas, because you're not just treating pancreatitis. And that could give biologic plausibility to pathways that you could block for generic pain. But anyway, more to come on that. I'm excited about that as a field in general. And I don't know, Dr. Anderson, if you will allow one quick last comment or not, because we are over time.
Go ahead.
That's Dr. Hughes.
Yeah, just two quick little things. One is I like studying the space of relapsing acute pancreatitis. As Dr. Freeman showed, he has a beautiful measure of a reduction in the frequency of acute attacks, which is a powerful measurement. My question for the committee as well, though, is, and it's actually from Dr. Neoptolemus, is do we need to measure fibrosis? And if so, I mean, do we do it with MRI or with EUS?
If only. One comment going back to the earlier comment about multiple endpoints. If we are in a situation where we are looking at a clinical trial that is intended to provide sufficient supportive evidence to support a marketing application, then certainly you run into a lot of trouble when you don't have an appropriate assessment hierarchy and multiple endpoints specified. At this point in time, we are all information gathering, and we are right here with you. We're waiting for the exciting news that you bring to us. And as such, having multiple exploratory endpoints in a trial such as the one going on right now in Birmingham and Mayo it's favorable. It's an opportunity that we can all learn from. It's an opportunity to explore novel biomarkers. It's an opportunity to gather data in a systematic fashion so that when the PROCEED study reports out in depth, we can compare it to natural history. So with that, and with what we're looking at in terms of PROs and attempting to identify concepts that may be important, it is not the only way. It is part of the way in which we are seeking to transfer and transform a highly complex disease process into something that is measurable from an improvement from a statistical point of view. And so that's where we are. I think I completely did not answer your question. I got on a tangent. I am so sorry.
Okay.
Yeah.
I think we've reached the end of our time period. And I want to invite Dr. Abu Elhaja to make some comments as the president of CAPER.
Well, I really want to thank the wonderful panel of speakers and all of you who did stick to the end of it. You're really strong believers in the disease. Thank you so much. This concludes our meeting. Thank you all for making it a wonderful experience for the speakers, moderators, attendees. We had over 70 abstracts, over 225 registrations from really a wide variation of representation, international and around the country. And I really would like to leave on a positive note. We will start planning the next Pancreas Fest committee as of August. So for my planning colleagues, be ready. And this will be in Cincinnati, Ohio, July 25, 26. And I think Dr. Dana Anderson also plans to have another wonderful NIH session preceding. So that would be the Wednesday. Please block your calendars, and I look forward to welcome you all in Cincinnati next year. Thanks all.